Presentation, I am going to discuss osteoarthritis and arthroplasty. I'm going to do it all in one little setting, okay? So do not get osteoarthritis, which is arthritis in the joints, confused with osteoporosis, which means weak and brittle bones that I'll talk about in class, okay? So osteoarthritis, the signs and symptoms include an outgrowth of bone spurs in the joints, stiffness and crepitus. Crepitus is like when sometimes I move my shoulder and I can hear like it creaking. Okay, that's what crepitus is. Tenderness, no redness, no warmth like in rheumatoid arthritis because this is not an inflammatory condition. It's only in the joints. It's not systemic like rheumatoid arthritis, okay? So usually it involves the knee and hip most often, and you will see people with osteoarthritis, they may be limping. I see that frequently. They kind of do a swing gait too if it's their hip. Pain usually improves at rest. The risk factors include older age, obesity, because that puts a strain on the joints, and joint injury. Okay, so like repeated joint stress. Usually it affects just one or two joints in the body, and it's not symmetrical, meaning what happens on one side doesn't always happen on the other. The complications of osteoarthritis include immobility. I used to work in a total joint center of excellence, and it was funny because a lot of times patients would suffer a long time with joint pain and limping, and they didn't want to get the joint replacement, but then they finally got it, and it changed their life because now they were more mobile and they could get back to doing the things that they enjoyed doing. So a total joint replacement is um, a great answer to osteoarthritis. So it's diagnosed with an X-ray. THR equals total hip replacement, so total hip arthroplasty, or total knee replacement, so total knee arthroplasty. Those are the two most common types of surgery for osteoarthritis. Now, people with rheumatoid arthritis can also have total joint surgery, okay? So for the nursing care, you're going to check the gait. You want to tell the gait means how they walk, right? You want to see how they walk. You tell them to bend at their knees and not their waist if they have to pick something up because it's just too stressful on the joints if they bend at their waist. Not to mention the muscles in your back. Encourage the use of assistive devices. We always want to keep people as independent as we can. Encourage rest. Heat therapy works very well for joints, like heating pads, moist heat. Maintain a healthy weight. If obesity puts strain on the joints, so maintaining a healthy weight would hopefully result in less pain. Medications are NSAIDs, and monitor the kidneys because NSAIDs are damaging to the kidneys. So you're going to monitor the BUN and creatinine, make sure they're not too elevated, and GI bleeding. So ask the patient about tarry stools. Ask about if they've been tested for bleeding. And then glucosamine and chondroitin supplements. They can take that. Now, chondroitin can lead to bleeding. So if they're going to have surgery, just like we talked about in the first lecture, if they're having surgery, it's the same pre-op and post-op process. All right, I just thought it was interesting to show you these hands, the differences. Like with the rheumatoid arthritis, they get that swan neck deformity, but with osteoarthritis, it's right at the top of their finger. Those joints are swollen, and it can be symmetrical in the hands, but in the body, it's osteoarthritis is not symmetrical. Okay, and here's a little rundown. Osteoarthritis is not inflammatory. It's asymmetrical. Rheumatoid arthritis is an inflammatory condition. The joints are going to be inflamed, red, and warm. Okay, and people with rheumatoid arthritis can develop Raynaud's phenomenon, which is when the hands turn from white from a lack of blood flow because of the arterial vasospasm, and then they turn blue, and then they turn red when the blood returns. So Raynaud's phenomenon happens with inflammatory conditions like rheumatoid arthritis, lupus. It can happen with lupus. It can happen with scleroderma, all those connective tissue disorders we talked about. Arthroplasty, that's a total joint replacement. The pre and post-operative care is the same. It can be quite bloody surgery, so the patient may undergo autologous blood transfusion, meaning they donate their own blood 6 weeks before surgery. Okay, they're going to be screened for infection. They cannot have any infection in their body when they have a total joint replacement because complications are tracked up to a year. And an infection, like I had a patient that had a tooth infection once, the surgeon wouldn't do it. UTIs, they will not do a total joint replacement. So we screen them for a lot of different infections, and they have like a really robust workup for their cardiac, like EKG stress test, okay, before they have that surgery. Post-op care, neurovascular checks after orthopedic surgery are done every hour times 24 hours, okay? So that's important to know. With the knee arthroplasty, they may have a CPM machine. So that stands for continuous passive motion. And this is what it looks like. And what happens is they turn this machine on, and this arm goes back and forth. So it straightens the leg, flexes the leg, straighten, flex. So it keeps the knee moving. You don't want the knee to get contracted. That's why they do that. All right. And then with the hips, hip arthroplasty, there's a lot of precautions with hip surgery. So they have this abductor pillow. So when you adduct, which is what you don't want to do, you add to the bottom. So the feet would come closer together. You do not want that for hip replacement. Your circulation must be checked. Remember, Q1 hours for the first 24 hours, and then Q4. Make sure these straps are not too tight because they could have an alteration in peripheral circulation if these are too tight, the straps, okay? You want total hip precautions. Follow that. So the bed needs to be supine with the head of bed elevated slightly. The affected leg is in a neutral position. And if they don't have this abductor pillow, they need pillows between their legs before they turn because you do not want to adduct the legs, bring the legs closer to each other. You want to avoid flare. That stands for flexion of the hip, adduction, and internal rotation. So internal rotation, the toes would be pointed in. You never want to see that. Your patient teaching for hip arthroplasty, when they're going home, tell them it's okay to lie on the operative side because many patients don't want to. For the first 3 months, they cannot cross their legs. They cannot adduct that leg. They need to put a pillow between their legs when rolling over or when they lie on their side in bed. Okay, so again, no adduction. It's okay if they bend their hip, but not beyond a right 90-degree angle. Okay, they can't bend beyond a 90-degree angle. Avoid sitting in low chairs. Use elevated seating in toilets. Use straight chairs with sturdy arms so that they can push up from it. Continue daily exercises at home and make sure they externally rotate their toes. So toes pointed like out because you don't want them to internally rotate. So again, avoid flare, flexion, adduction, and internal rotation. Instruct the use of assistive devices like they have really long shoe horns to get their shoes on, dressing sticks, raised toilet seats, very important. And for knees, they cannot do deep knee bends for life. I used to cycle with a few people that have had hip replacements and knee replacements, and they started cycling because they weren't allowed to run anymore because it puts too much pressure on the total joint. All right, so that's it for osteoarthritis.